Good morning. Welcome to the Department of Medicine Grand Rounds. We have a special guest today, and of course, we bring special people to celebrate some of our special people. And we'll have a few people to come in and introduce them. But I would just want to say a couple of words. Number one, there's the flu shot people are out there. So if you want to have your flu shot, like me this morning, I just came in. I didn't know they were here. I just had my flu shot, so that's terrific. Number two, we always take this opportunity to remember people and events that have changed the way we think about medicine, biology, healthcare. So I want to remind you that on this day, back in 1928, the iron lung was used for the first time on a young woman with polio. And that was at Children's Hospital in Boston. The machine was actually developed by a young Harvard doctor, Dr. Philip Drinker. So just remember that because the era of mechanical ventilation and critical care and standardization of care and all that evolved after these episodes. We've also talked last week and this week about the Nobel Prize. And on Tuesday, during faculty meeting, we talked about two important Nobel Prize winners. And you know the Nobel actually used nitroglycerin, did a concoction and developed dynamite, and he developed a fortune doing that, and this is developed in his name. What we don't remember is Ascanio Sobrero. And Ascanio Sobrero was born on this day, back in 1812. He was the one who discovered nitroglycerin in 1847. He felt it was extremely destructive, so he refused to continue to work at it. It wasn't until Nobel took it over and developed dynamite and so forth, and was easier to control and less dangerous. But remember that Ascanio Sobrero was an Italian chemist who actually discovered nitroglycerin in 1847, born on this day. With that, I'm going to leave you with Dr. Don Miller, who's going to talk to you about Dr. Yam and the reason we celebrate Dr. Yam today. I'm going to have to leave it a little bit earlier, not because this is not crucially important. It's because I'm covering the pulmonary service at the VA, and I'm already 15 minutes late for a bronchoscopy that couldn't be delayed. But I'm sure you're going to enjoy this a lot. Dr. Miller.
So it's a privilege to introduce this lecture in honor of my friend Lung Yam, who was really a great faculty member in our division and department. I'd like to recognize Mrs. Yam, who's here today and who's actually helped us as we arranged these lectures. Lung Yam was born in Canton, China, and went to medical school at the National Taiwan Medical School in Taiwan, where he met his wife. They came to Chicago after that, where he did his internship and residency at Cook County and St. Elizabeth's, and then he went to Boston to work he worked with Bill Crosby to do his fellowship at the New England Medical Center. And Bill Crosby was probably the preeminent hematologist in America during those times. And Lung and Bill Crosby hit it off, and when Bill Crosby went to San Diego to head up Scripps, Dr. Yam went with him and then came to Louisville in 1974. And he really built his career from 1974 through his retirement in 2011 and was nationally and internationally recognized as a leader in hairy cell leukemia and the development of the tartrate-resistant acid phosphatase assay, the TRAP assay, which is now widely used as a standard assay. Lung was a great teacher. He was loved by the students and fellows. He did a morphology class every Friday afternoon. The fellows loved it. He was one of the last great classical hematologists. His patients loved him. He had very, very busy clinics at the VA. But beyond that, Lung was just a great human being. He was a great husband, father, and friend to many of us. And so I'm very, very pleased that we're doing this lecture in his honor. Thank you very much.
Good morning, everyone. Today I have a distinguished honor to introduce our 2017 YAM Memorial Lecture speaker, Dr. John Fung, Professor and Chief of the Transplant Surgery Division and Director of Transplant Institute at University of Chicago. For the past 30 years, Dr. Fung has been involved in many aspects of organ transplant, including clinical practice, donor management, analysis, outcomes, clinical trial, basic science, immunobiology, as well as transplant policy and ethics. He has published more than 1,000 manuscripts. I don't know how John can do it. And also 100 chapters, and also serving as an editorial board member for multiple high-impact journals, including being the editor-in-chief of Liver Transplantation, the highest impact factor of any organ-specific transplant journal. Dr. John Fung, a native from Bethlehem, Pennsylvania, received his BA degree at Johns Hopkins University and MD Ph.D. from University of Chicago. He completed his residency training in surgery at the University of Rochester. After that, he went on to receive organ transplantation training and translational research in transplant biology with Dr. Thomas Stassel, the father of liver transplantation at the University of Pittsburgh. He then moved up his ranks from research fellow to tenure full professor there. In Pittsburgh, John had many groundbreaking immunology researches and revolutionary surgical technique, along with Dr. Stassos. Notably, his lab developed the tacrolimus, the most commonly used immunosuppressant for transplantation of any kind. His work on tacrolimus, including from laboratory to clinical applications, including our bone marrow transplantation practices. In 1992, he led a surgical team at the University of Pittsburgh to perform the first ever baboon to human liver transplantation. And at the time, I was a postdoc fellow at the Children's Hospital in Toronto, so I still clearly remember watching the CNN breaking news, and John was sit side by side with Dr. Stassel for the news conference. After University of Pittsburgh, John also had many important academic appointments, including chairman of surgery at the Cleveland Clinic Foundation, where we briefly overlapped when I was a faculty member at the Case Comprehensive Cancer Center. He recently was recruited back to his alma mater, University of Chicago, to be the director of Transplant Institute, as well as the chief of the surgical transplant division. There's no better choice of a speaker than Dr. John Fung for today's prestigious Yam Memorial Lecture to honor Dr. Yam. Why? Because Dr. Yam, who discovered the early diagnosis method of hairy cell leukemia, it fits wonderfully today's discovery and pioneer theme. As today in 1492, Christopher Columbus makes a landfall in Caribbean, specifically in Bahamas, and when he believes he found a new world. So this is a really good lecture and timing to celebrate Dr. Yam.
Well, I'd like to thank Dr. C for the kind introduction. It's always a pleasure and somewhat of an oddity for a surgeon to give Department of Medicine grand rounds, and it's an honor, in my opinion. What Bill didn't tell you was I actually wanted to be a hematologist. In medical school, I trained, John Altman was my advisor, but he thought I had a better personality suited for a surgeon. I don't know if that's a compliment or an insult. Anyway, so I'm going to talk about a culmination of 30 years of my own research, and I hope you can see the parallels in the area of cancer immunobiology, which was my other alternative, besides being a transplant surgeon, was to be a surgical oncologist. But as I did a little bit of investigation about Professor Yam, which you've already heard today, I also would just emphasize that this was a pretty impressive accomplishment. Has been continuously cited since 1968. His H-index is 45, and for you that don't know what H-index is, it's a citation index. Anything over 40 is considered an expert in their field, and this single paper has been cited over 3,400 times since its publication in 1971, which is very impressive. And I think the comment in his obituary that he was a prolific researcher and an authority on blood disease and diagnostic biomarkers is clearly evident in the work that he's done, and my hats off to him and his wife, Julie. So my objectives today is just to really talk about immune tolerance and what it is, what we've uncovered. It's studying transplant tolerance, but clearly applicable now that we understand more about cancer immunobiology and what the consequences of those will be. So I entitled this talk Good, Bad, and Ugly. So from a transplant perspective, the good, this is the longest surviving kidney transplant recipient of a non-identical twin, HLA non-identical. Bob Phillips lived 54 years off of immunosuppression, having received a kidney from his sister 54 years ago. The bad, well, we sometimes think we can control acute rejection, but the consequence of chronic rejection, which we really still don't understand. This is a picture of a arteriopathy, allograft arteriopathy that can lead to graft failure, be it the heart, the kidney, the liver. And then the ugly, and I'll tell you what this is. This is a liver at postmortem of a liver transplant recipient off immunosuppression who unfortunately acquired a donor-transmitted melanoma. And all those spots you see are melanoma cells. So we can achieve tolerance, but sometimes the penalty that we pay can be quite high. Now, from this other side, from oncology, immune tolerance is not a good thing because it causes cancer progression and establishing progression of cancer. This is Emily Whitehead, I think everybody knows, from Pennsylvania, central Pennsylvania, who received the first pediatric CAR T cell for her acute lymphoblastic leukemia, is now in remission. The bad being the use of these immune checkpoint inhibitors can lead to exacerbation of autoimmunity. And this is actually the biopsy of a GI tract showing gluten enteropathy in a patient who developed gluten intolerance after nivolumab treatment for lung cancer. And then the ugly, William and I were talking about chronic GVHD, where you really have tolerance, but unfortunately the tolerance is unidirectional, and you have now chronic graft versus host disease. So the history of understanding immunobiology as it relates to transplant started into the 1940s. This is Sir Peter Medawar, who was a British officer during the Battle of Britain in 1940, prior to the onset of World War II, was involved in burns of soldiers using skin of cadaver soldiers as dressing for burns. And he made some interesting observations that went on to lead to understanding that skin rejection really was a lymphoid-mediated rejection. This is a picture not of a soldier, but of a woman who had sustained third-degree burns, and the little white dots on the left side are skin-punched biopsies. The bottom part are from her own skin, the top are from her brother, and you can see that in the center slide, the skin grafts from her own self coalesced, forming a continuous skin coverage, but the ones on her shoulder have not. And when they did punch biopsies, you see on the right the pathology showing the very typical cellular infiltrates that are typical of rejection. Simultaneously, and simultaneously studied, but a few years later, Jean Dassay and George Snell unraveled some of the mysteries of the major histocompatibility complex, in which differences were eventually determined to be the cause of transplant rejection. And then in 1960, speaking of Nobel Prizes, Peter Medawar and Frank Burnett both received the Nobel Prize for understanding tolerance. And this model of tolerance that Billingham, Brent, and Medawar described was a neonatal injection of neonatal animals with unidentical skin grafts from parents that were eventually accepted, and this is because there was a central deletional model of tolerance, and they received the Nobel Prize for this. Now, as it relates to transplant, the other Nobel Prize winners that I think you can appreciate, at least half of it would be Donald Thomas in the area of bone marrow transplant, and in surgery, Joe Murray. And as you'll see, Joe Murray was responsible for kind of reviving the whole field of transplant, which had undergone failure after failure after failure prior to the transplant of kidney from identical twin donor to the recipient. And obviously there's total HLA compatibility, so there was no rejection, and you can see this couple brothers in the right-hand corner and the operation going on. And for this, he won the Nobel Prize for that aspect of surgery, and then the work that Donald Thomas did using not autologous but identical twin bone marrow for 2 pediatric patients with acute leukemia, showing that this was able to rescue patients, although it turned out not to be a great treatment. Donor versus tumor benefits in this case, and so, but at least it validated the concept of a bone marrow transplant. Now, in 1961 to 63, the advent of azathioprine and prednisone allowed several investigators, including Tom Starzl at the University of Colorado, to undertake a series of kidney transplants using azathioprine and prednisone. And by 1963, he had accumulated 64 patients, which he had reported. And by 2009, 8 of those patients were still alive. And this is a picture I showed you before. And many of these patients were actually off of immunosuppression, 6 of the 8 that were surviving as of 2009. When Bob Phil, as shown here, died 2 years ago, he had normal kidney function. So I like this picture because the concept of tolerance and how then you take it to clinical practice sort of devolved in the area of bone marrow transplant and solid organ transplant, because we had potent immunosuppressive drugs, perhaps the challenges of getting engraftment and the transplant versus tumor benefits, which were not an issue for solid organ transplant, but for bone marrow transplant, kind of devolved in that tissue matching was thought to be critically essential for bone marrow, but not for solid organ. Graft take leading to tolerance versus chronic immunosuppression, and then graft-versus-host disease, which was rare in solid organ transplant, but very common in bone marrow transplant. And Dr. Starzl actually adopted this concept for our logo for the Thomas E. Starzl Transplantation Institute. Now, after this, from 1983, when the T-cell receptor was first identified, a number of different investigators, and this is a short list of some of them, went on to identify the signaling pathways for T-cell receptors, the necessity for co-stimulation or signal 2 pathways, and then a number of checkpoints, which obviously you'll see has been the common theme between transplant and oncology. So besides the signal 1, which is T-cell engagement with the MHC of the APC or the target tissue, signal 2 then constitutes usually a positive in naive T cells, but can also be a negative signal. So the stimulatory signals being the CD80, 86 binding to CD28 on the T cell, being a positive signal. There are other co-stimulatory signals, CD40 with CD40 ligand, B1BB, 41BB with its ligand on the APC being all positive. And then the negative intrinsic regulatory pathways of CTLA4 binding to CD8086, as well as PD1 and PDL1, which I will focus most of my talks on, the rest of the talk in this pathway of the PD1, PDL1. Now, we can see that over time, the definition of immune tolerance has changed. Initially, classically, you can define it as failure to mount immune response. It could be, doesn't define the mechanism of why that's a case. From a clinical standpoint, it's a state where it's either associated with health or disease and doesn't necessarily differentiate them. So it's most patients have the tolerance unless they have an autoimmune disease or some other disease process, or the mechanistically, which is what we're trying to identify in the animal studies that I described now. It's either a central deletional tolerance, which is a thymic type of tolerance, versus a peripheral tolerance, which is probably now thought to be much more important in adult patients. Now, in transplant, because most of our patients are adult patients, they have a pretty set immune system. They've already been exposed to a number of antigens, and so they have a lot of memory T cells. And so it's very hard to get this deletional neonatal tolerance that we can get. Clearly, if we irradiate them, give them lots of chemotherapy, like you do in bone marrow transplantation, you can get tolerance and engraftment of another immune system. And subsequently, if you put a transplant in from that same donor, you'll get full acceptance. But that's not, it has its own issues. Now, when I first got involved in study of liver as its role in immunity, I was really interested in tolerance. Clearly, there are a lot of signals that the liver is important in maintaining systemic tolerance. We know that all the food that you ingest, the foreign antigens, the bacterial antigens, the lipopolysaccharide, everything that goes through the GI tract, if you don't have a filter in the system, which is your liver, you have to develop all sorts of GI, systemic inflammatory responses as well as autoimmunity. And as an example of that are patients who are cirrhotic, who have portal systemic shunts, have all sorts of abnormalities in their immune system. You've often heard the liver as a graveyard for activated T cells. It's some people think it's a killing field, and I'll explain to you why that's the case. And we also know that the liver, when exposed to chronic viral hepatitides like hepatitis B and C, are faced with the challenge of eliminating the pathogen, which is hepatitis B or C, and the resultant damage associated with that, and the chronicity then that establishes the scarring, fibrosis that leads to cirrhosis, and sort of this balance that the liver has to do, trying to get rid of the inciting agent while not killing itself. And we also know that we suspect that the liver is a site for many metastases because of this sort of immune privilege site that the liver has. In transplant, we know from experience by Roy Kahn back in 1969, you can actually transplant pigs' livers from totally disparate pigs and often get transplant tolerance without the need for immunosuppression. Livers can reverse ongoing rejection of other donor organs. We showed that in the face of a positive cross-match, a liver allograft can neutralize that. Indefinite survival, as I'll show you in the mouse models of liver allografts without immunosuppression. And then, as part of what Dr. C was saying, my interest in xenotransplantation, this is a rat receiving a liver from a hamster, and then two months later, getting the skin graft of a hamster. You can see that engrafted versus a mouse, and C3H, which was rejected. And so the tolerance associated with liver transplantation can be quite robust. Now, the problem in clinical transplantation is that we use chronic immunosuppression, and there's a lot of complications associated with long-term immunosuppression. And this is associated with establishment of or risk for de novo malignancies, other viral infections. It compromises quality of life by increasing the cost and a lot of compliance issues when you're taking a lot of medication. And so we like to think that if we can unravel transplant tolerance, we may be able to apply this to other organs besides the liver and also to other autoimmune disorders. So we undertook back in the early 1990s a series of prospectively studied patients that were undergoing immunosuppression withdrawal for a number of complications, be them viral or like post-transplant lymphoproliferative disorders, renal dysfunction, et cetera. Anyway, and a number of series, and on even more recently from 2007. But most of these studies suggest that about 1 in 5 to 1 in 4 liver transplant patients could be weaned off their immunosuppression and be quite stable without any subsequent complications. But the penalty to pay, as you can see, about while only 1 in 4, 1 in 5 patients can be taken off immunosuppression, 1 out of 2 will actually experience a chronic rejection, an acute rejection during the weaning phase. So this trial and error is fraught with some complications or some risk to the patients. There are a number of factors, and we'll go over them all based on the series. And the problem is, what you will see is that there is no uniformity in the series in terms of what are common factors that may be associated with liver transplant tolerance. And so using more genetic approaches, people have looked at genome-wide associations, looking at patients who are off immunosuppression versus those that rejected while coming off immunosuppression, to look for biomarkers or genetic markers that would identify patients who could be successfully withdrawn. And this is recently published, and there have been a number of papers that have continued to investigate this. Safe to say that there are certain types of genes that are associated with apoptosis signaling, some other factors that are, you can see here, mitochondrial dysfunction, NK cellular signaling, T cells, gamma delta T cell signals. But these are associations and do not provide a basis for us to look at mechanistic approaches. It could be useful, as shown in this bottom panel, in prospective weaning protocols going forward, taking patients off of immunosuppression, using these markers, genetic or biomarkers, to reduce the risk of chronic acute rejection by being able to call out the patients that have a more favorable predisposition to being able to be weaned off immunosuppression. So I mentioned because we don't have a good mechanistic, certainly hard to study in humans, we went to the mouse liver transplant model, and this is quite challenging. These mice are 25 grams versus human, as you know, is 70 kilograms. Technically, doing a mouse liver transplant is quite challenging. The mouse liver is only about 5 grams. And so we developed a microvascular core to do this. This is, for the surgeons in this room, this is exactly what we do. It's orthotopic placement of the transplant. We do all sorts of combinations. The one that we'll talk most about is the B6 to C3H, which is a fully MHC incompatible H2B to H2K transplant. And to summarize, just to tell you that what we have found and have validated in other models of the rat and the pig are that, and particularly more so in the mouse, that liver allografts are spontaneously accepted in spite of an apparent initiation of immune reaction that is indistinguishable from rejection. And after the development of tolerance, these animals demonstrate a clinical tolerance, unresponsive to donor-specific alloantigen, but they retain an in vitro reactivity to donor alloantigens. In other words, the T cells are there, but they don't react. So this is the histology of a liver from a mouse transplant on day 7. You can see the infiltrate, periportal infiltrate, and any pathologist would say this is rejection. And without immunosuppression, 5 weeks later, the infiltrate is gone, and it looks perfectly normal. So when we take the cells out of these livers and we study them, here we do a cytotoxicity of the cells that come out. The red are against allogeneic targets, so these are against H2B. Remember, I told you this is H2B to H2K combination. So the targets here are H2B. You can see very brisk cytotoxicity at 7 days, starting to come down at day 14. And by day 110, where the grafts are totally normal, there is no cytotoxicity, and you see the appropriate controls. But if we take the spleen out of the same animals, you can see that at day 110, there are a lot of cells that are capable of rejecting, but they don't, they're there in the spleen, but they don't react against the liver. And to demonstrate the ability of the liver to protect a second organ from the donor against rejection. Again, long-term survival greater than 100 days with the liver alone. The hearts are rejected between 10 and 12 days. If we do a combined liver-heart from the same donor, the heart is accepted as well as the liver for more than 100 days. If we do the liver with a congenic or H2 disparate heart, you can see that there's specific recognition of the B10D2 heart is rejected in 12 days. Now, the baseline immune status of the recipient is important because if we pre-treat the donor or pre-treat the recipient to increase the inflammatory signals, we can get rejection. I won't go through all of these. I just would mention, interestingly, like that treatment with anti-CD25 inhibits liver allograft acceptance. And this is interesting because one of the drugs that we use commonly in transplant is an anti-CD25 receptor, an alpha receptor of the CD25, and or basiliximab, and it's just interesting. I'm wondering whether or not long-term with these, whether or not we're going to be able to wean patients off immunosuppression or not. But anyway, so I showed you already the H&E stains of these. We started to look at apoptosis as a mechanism for why these cells disappear. And you can see that the C3H mouse at day 7, really very little infiltrate. The B10, the C3H, you start to see some infiltrates at day 4. But day 7, very brisk ongoing infiltrate. But the brown spots are all cells that are undergoing apoptosis. And if we do a tunnel stain, which is an assay to look for apoptotic cells, you can see that in the C3H, B10 to C3H combination in the black, the percentage of cells undergoing apoptosis is quite high. In fact, 40% of the cells by day 7, 20% of the cells on day 14 are undergoing apoptosis. So looking at the kinetics between CD4 and CD8, CD4, they're in the square box on the right top, being present, not showing any decrease in percentage of cells, whereas the CD8 in the open square boxes show this dramatic decline. When we look at the remnant cells in the CD4 population with FOXP3, which you know is a signal for regulatory T cells, also with CD25 positive, 20% of the CD4 cells that are present on day 40 are already regulatory T cell phenotype. Now, the question that we had then was, is it that what cellular population in the liver is responsible for this tolerance? If we put the whole liver in, we get long-term survivor. If we just give them isolated hepatocytes, you can see that those are rejected by 10 to 12 days after transplant. Now, the cellular composition of the liver is really about 60% hepatocytes, a few bioductular cells, and then a whole host of other non-parenchymal cells. These include the liver endothelial cells, the Kupffer cells, stellate cells, other types of T cells, they come out, alpha, beta, gamma, delta T cells, B cells, NK cells. We were very interested in the stellate cell, and I'll explain to you why later on. But it comprises a minority of the cells of the liver. It has, as you know, the main retinoid storage, vitamin A, in the entire body. 80% of vitamin A is stored in the hepatic stellate cells. They're involved in fibrogenesis, cirrhosis, and extracellular matrix production. Usually they live quiescently in the liver, but if they're activated through a number of signals, they will transform into myofibroblasts. They become alpha smooth muscle actin positive, and they can proliferate and cause all sorts of trouble. We went back to these stains, and then these slides, and sections, and we stained for GFAP, which is glial fibrillar acid protein, and which is a marker for hepatic stellate cells. And you can see that they light up very brightly in this immunohistochemical staining. And when we went and quantitatively, these cells are increased in the portal tracts of animals that are undergoing spontaneous tolerance. So we then, Shekhar Gandhi, who is a cell biologist in our area, who is very interested in hepatic stellate cells in fibrogenesis and cirrhosis, helped us develop a model to isolate hepatic stellate cells. And using a Pericol gradient, we can separate hepatic stellate cells from other bone marrow-derived leukocyte populations within the liver. If you sort them out, you can see in the open box these, which are the control CD45, and the dark box, the dark plots, which are the hepatic stellate cells. So they express very low class 1, very low class 2, and no CD45. If you activate them, they have many of the characteristics, desmin and smooth muscle actin. The other thing that you see when you activate these cells, usually we do it with gamma interferon, is that they upregulate this PD-L1, or as I'll call it, B7H1. We use the old terminology of B7H1. And so, as you know, B7H1 or PD-L1 is a interesting molecule because it induces T cell. It is involved in the signaling for T cell apoptosis, T cell anergy. It is a dose-dependent mechanisms and time-dependent, so the more interferon you give, the longer you wait, the higher shift you get of quiescent hepatic stellate cells to upregulate this B7H1 or PD-L1. Now, we know interferon gamma is important. If we use interferon gamma knockout mice, they are rejected. So gamma interferon is important in this model. We presume that it helps to upregulate and activate hepatic stellate cells, then to kill or cause activated T cells to undergo apoptosis. And we look histologically, the green being the CD8, red being CD4, and the left right-hand panels, you can see the wild type at day 14 versus the interferon knockout in the middle, a lot more green spots on the right side, suggesting that the gamma interferon knockout animals accumulate CD8 and are unable to undergo apoptosis. And the control animals being wild type by day 77, there are no green cells left. So hepatic stellate cells can only inhibit T cells when they're activated. So quiescent hepatic stellate cells don't have the same ability to inhibit T cell proliferation as activated T cells, and that's shown here in the red compared to the quiescent cells in blue. And we know this mechanism of apoptosis of activated T cells is mediated through B7H1 or PD-L1. And you can see here that if you use an antibody to PD-L1 or B7H1, you can inhibit apoptosis, and that's shown in the blue box on the right compared to the controls in the middle, green and pink. The other thing we know is that if we use a B7H1 knockout liver, so the hepatic stellate cells are B7H1 deficient, these livers undergo rejection. So if you look at the left-hand histology, the mean survival time is 6 days in the B7H1 or PD-L1 knockouts versus the wild type, which have indefinite survival greater than 100 days. And you can show the annexin 5, which is apoptosis marker, in the B7H1, very few of the cells are undergoing apoptosis as compared to the wild type shown in the right top, where there's a substantial portion of the cells are undergoing apoptosis. So we were now interested in looking at hepatic stellate cells outside the milieu of the liver. And so we used a model of co-transplantation with islets. So here, the hepatic stellate cells are taken out of B6 mice, H2KB, and incubated with BALB-C islets, H2KD, and put into an H2 BALB-C streptozotocin-induced diabetic mouse under the renal capsule. And we know that it's a hepatic stellate cells that induce islet function and prolonged survival. That's shown in the top curve here. If we use controls without any, just islets alone, you can see the rejection in the open squares. And then the curve that's in the middle are endothelial cells derived from the liver, and they offer no protection in terms of graft islet function prolongation. We know that these are functional because if we do a graft nephrectomy at day 63, then the patients are rendered diabetic. This is what the subcapsular injection of islets along with hepatic stellate cells look like. It's very interesting. You can see the neovascularization, and I'll just say without showing you the data, but we've looked at this. Hepatic stellate cells synthesize a lot of VEGF, and this induces neovascularization of the graft. And when we look histologically, on the right upper panel, you see what the islets look like in a islet alone. And you see this brisk cellular rejection. The animals are already diabetic by day 7. Whereas the combined hepatic stellate cell islet group at day 126 shows, and the red are insulin-producing cells, as well as this pseudocapsule around the islets that are smooth actin, muscle actin positive. You can see that in the green at the bottom. So Hung Jen Yang did an analysis and showed that in our lab that in the islet alone group, you can see a very brisk proportion of CD8 positive cells. And when you co-transplant them with islets, this at the same time on day 7, the number of CD8 positive cells are markedly decreased on day 7. And then long term, when you look at this, you see very few CD8 cells in the graft, but a fair number of CD4. These are the islets on the side. When we we know that this mechanism, again, is PDL1 and B7H1 mediated, because if we use hepatic stellate cells that are B7H1 deficient, the proliferation index, this is a CFSE, and the more shift to the left, the more proliferation of T cells. This is a wild type, and so you can see that T cell proliferation is reduced, is markedly suppressed. And if you use B7H1 knockout hepatic stellate cells, they're unable to suppress T cell proliferation. The other thing that we did is looking at these long-term grafts is stain for FOXP3. As you know, FOXP3 is a marker for T regulatory cells. You can see that in these red cells that are CD4 positive, the nuclear staining of FOXP3s. So what CD4 cells are left are mostly FOXP3 positive. And that's also shown on this slide. I'll skip that. So this is what the kidney looks like. You can imagine the skill it takes to not only inject these, but then study the draining lymph nodes from these. These are, the whole kidney itself is only about 4 millimeters. So taking out these lymph nodes, collecting them, and then analyzing them. What we found in these draining lymph nodes is a high percentage of the cells in there are T regulatory cell phenotype, of the T cells are T regulatory cell phenotype. We also know that these in vitro hepatic stellate cells can generate CD4 positive FOXP3 regulatory cells in vitro and are capable of suppressing T cell proliferation. This is the model of CFSC suppression in the cell controls that are FOXP3 positive. So we ended up coming up with a schematic that looks sort of like this. We start with an alloantigen, donor dendritic cell. This could be in the liver, the kidney, whatever, generates T cell activation, and then this T cell generates interferon gamma, at least in the liver, induces quiescent T cells to become activated T cells. I'll talk a little bit about this at the end because I think it's really exciting and potentially an area for intervention in inducing a regulatory pathway. The hepatic stellate cells then generate Tregs. These Tregs suppress T cell function, and I'll just focus a little bit on these, which are the myeloid-derived suppressor cells. So what are MDSCs? Myeloid-derived suppressor cells in cancer, as you well know, are associated with cancer staging. So the more MDSCs there are, the usually associated with worse tumor characteristics. And I'll show you briefly and summarize that hepatic stellate cells are very potent inducers of MDSCs. MDSCs have a wide variety of activities that can suppress other types of immune activity. Let's see. So these are what they are. They're heterogeneous population of cells of myeloid origin. They are characterized by increased production of reactive oxygen species and nitrous oxide and arginase. They suppress T cell function. At least in the mouse, it's easy to study because they have a phenotype that is CD11B positive, CD11C negative, and GR1 positive. In humans, it's been a little bit more challenging to identify because the markers overlap with other non-MDSC populations, but I think this is an area for research, and maybe we should have Dr. Yam work on this, some of his students to identify MDSC phenotypes. But anyway, when we go back to our mouse liver transplant model, and we now sort for CD11B and GR1, we can look at a population that are CD11B positive with intermediate or high levels of GR1. This is what the phenotypes look like. You can see these often look like neutrophils. And when you put these in culture, you can see a marked suppression. These are control animals, again, CFSC dilution during proliferation. And in the GR1 intermediate group, the CD11B positive, in the liver itself versus the spleen, you get marked suppression of T cell proliferation. So going back to the hepatic stellate cell islet allograft model, we looked at the presence of MDSCs. Now, I kind of mentioned we already looked at FOXP3, but if we look at CD11B, CD11C, and this should be negative, I'm sorry, you see that in the islets, I'm sorry, these are positive. So the islets that alone have a high percentage of CD11B and 11C positive, and in the tolerant islet hepatic stellate cell, very low staining for 11B and 11C positive. So when we then look at whether or not these cells are donor or recipient origin, these, remember, are K2D to K2B. The cells are, K2D to K2B. These are all recipient origin. So these are recipient phenotype. They also have marked elevation of B7H1 compared to 76% versus 51%. These MDSC type phenotypes are synthesized iNOS and arginase. These are from in vitro cultures of cells taken from islet hepatic stellate cell animals versus islets alone, where there's significantly less iNOS and arginase. And when these cells are mixed in culture with, you can see the T cell response and proliferation in CFSC is decreased, both in the CD4 and CD8 population. And then the annexin 5, which is a mark for apoptosis, is elevated in these animals compared to the control in islets alone. If we take these cells, they are almost as effective as using hepatic stellate cells in protecting islets. So if we use a co-culture of or co-injection of islets and these hepatic stellate cell generated MDSCs in vitro, we can also get prolonged survival of the grafts. These are the hepatic stellate cells alone, and then our control groups. So one question that we had was to, now going back to what I had showed you with humans, looking at genetic mapping and markers. One of the things that came up in our review was the presence of C3 in this, which is mapped out to this class of apoptosis anti-proteolytic markers. And this was also consistent with another group from Australia showing that the overlap of their three models had one common marker, which is the presence of complement 3. And a study from a long time ago from Bob Colvin and MGH suggested that if you had an animal who was C3 deficient and you gave them simply administered antibodies or donor-specific antibodies to the kidney, you can develop these florid chronic allograft vasculopathy that you wouldn't in the C3 animals, but not in the C3 normal animals, wild type. So I'll just mention that this sort of took our, and we also added to our group, Feng Lin, who was a complement guy from Case Western, and identified that there is a role of complement in the generation of MDSC. Also, one of the graduate students in our lab, Samantha Bott, looked at specifically the role of retinoic acid in generating arginase 1 and iNOS in our T cells, and also demonstrated that retinoic acid is important. I won't go over the specific results of that, but I do want to show you some interesting, more recent data that looks at hepatic stellate cells generating their own factor B and factor D. As you know, factor B and factor D are important in the generation of C3 and C3 activation. These hepatic stellate cells in either factor B deficient or factor D deficient serum can demonstrate its own synthesis. And if you add these factors to C3, you generate an IC3B, which is a breakdown product, inactive C3B, and these can stain the MDSCs. And if you take these and you add IC3B to cultures of MDSCs, you can see a stepwise suppression of activation. This is CD11C positivity. So CD11C positivity is a marker for myeloid DC maturation, and the less CD11B, these are all less CD11C, these are all CD11B positive, the more phenotype they look like of MDSC. So we think that IC3B is an important molecule in the whole generation of MDSCs. So we recently published sort of a review of how transplant immunobiology and cancer immunobiology sort of interact. And I think, classically, and we know this is also very simplistic, looking at cancers breaking, either through apoptotic death or necrotic death, generating fragments that can then be processed through APC, activating T cells, then allow them to traffic into the cancer cell, engage with appropriate receptors on the cancer cell, and induce cancer killing. So that's sort of, the mirror image of our rejection process. But we do know that cancer cells, similar to our hepatic stellate cells and other types of immunosuppressive or immunomodulatory cells, express on their surface probably through the same mechanism of interferon gamma activation, the presence of these immune checkpoints, PDL or B7H1, and these then can inhibit T cell activation through the ligation of PD1 and subsequent T cell energy. And this gives you, as you all know, an opportunity to intervene at a cancer level using immune checkpoint inhibitors, either to PD1, PDL1, or interfering with the co-stimulatory blocker CTLA4, which is upregulated in activated T cells. And by doing this, all of these, we hope to be able to rescue anergic or unreactive T cells to be able to become responsive. So I'll just end by saying, from my standpoint, my interest in liver, that it clearly has tolerogenic properties, and it has a specific reason for doing that, to minimize the systemic activation as a result of GI factors. And the stellate cell, we think, is a principal mediator, and like many other mesenchymal stem cells or stromal cells, have the same ability to suppress T cell activity, and probably important in maintenance of peripheral tolerance. This is done through several important molecules, but the PDL1, B7H1 mediated apoptosis is probably very important, particularly in transplant, at initiating suppression of the first wave of T cell injury. And then subsequently, the generation of MDSC, CD11C negative, CD11B positive, as well as T regulatory cells, are important in maintaining the graft without the use of immunosuppression. And I think that there are other potential interesting areas to look at, including the role of complement 3 and its inactivation product IC3B, as well as retinoic acid as potentially mechanisms or areas to intervene to enhance immune regulation, immune responsiveness. And I think it's becoming clearer, as I mentioned, that some of the strategies that we're using in transplant are the exact opposite of what you want to do in cancer, but I think we can learn quite a bit together. So with that, I just wanted to end. There is actually another reason I call this lecture Good, Bad, and Ugly. I don't know how many of this movie have ever seen this movie. It's a really bad movie, but it's classic. It's classic. So if you've never seen it, you got to go see it. So one of the things that's interesting about this movie, Sergio Leone, who's the director of this movie, had a very interesting thought of when he was making it, that the camera is the only thing that you can only see through the camera. And so you presuppose a number of different contiguous parts of the scene, but when you see the film, you'll see these things appear in the picture that don't make sense or that you hadn't anticipated. So when I call this Good, Bad, and Ugly, it's sort of the same concept. We think of transplant immunobiology in this certain frame, and then once you look outside the frame, you get a bigger picture. You realize this is a process which has many ramifications, not only on immunity and cancer, but just in normal physiology, in the normal physiological response to environmental stimuli, et cetera. So anyway, with that, I just wanted to thank our research group. This started when I was in Pittsburgh. I went through a time that I was in Cleveland, and unfortunately, my two senior investigators, Lena, Liu, and Chen, decided to retire at the age of 72. I don't know why they wanted to retire when I moved to Chicago. But we're still collaborating with Feng Lin in Cleveland, and also Robert Fairchild, who I forgot to put in this, Jake Demetrius and Angus Thompson, both at the University of Pittsburgh, and some other collaborators. Thank you.
Dr. C and Dr. Roman to take Dr. Roman's place today, and so I get to do the Q&A.
Okay.
And Dr. Roman has a tradition. You always ask the first question from me, and I always thought that was kind of greedy. But I'm going to do it. I noticed early in your talk that you mentioned that giving an anti-CD25 antibody would actually cause rejection, despite the fact that in these allogeneic models you weren't getting it. And then moving through your talk, you started talking about regulatory T cells and MDSCs. CD25 is very highly expressed on regulatory T cells.
Correct.
So I just wonder if that was in fact the reason for that. And I have to admit, I stepped out for a call. I don't know if you mentioned that at the end.
I didn't mention it, but that's our supposition also. So CD25 is a marker for activated T cells. It's present on any non-naive T cells. So memory T cells, regulatory T cells, et cetera, activated T cells have CD25. What's interesting, and again, indirect evidence that CD25 is important, is a study that came out looking at registry data on induction immunosuppression in populations of liver transplant patients. And interestingly, if you get anti-CD25 induction and you have hepatocellular carcinoma, those patients actually protected from developing HCC recurrence. It's an interesting phenomenon, and I presume, again, it's probably related to suppression of these MDSC regulatory T cells with a short course of CD25 up front. So, there's lots of interest. We know that's true in animals. In our animal models, we can prevent tolerance by giving anti-CD25. The question is whether or not this has the same ramification in humans, and I don't know the answer.
Okay, any questions? Yes.
A little bit different. Restricted fashion? No. The answer to that is no. Yeah. MDSCs work in a non-MHC restricted fashion, which is interesting. Whereas hepatic stellate cells their activity is they're best against or MHC matched, but they also have a component that's non-MHC restricted. So the tolerogenic DCs in the peripheral are different because they have DC markers. Hepatic stellate cells don't carry 11B, 11C. Those are more like mesenchymal stem cells, MSCs, than they are DCs. They have very low, constitutively don't have much of either. You can, with interferon gamma, you can upregulate class 1. They don't really present antigen very well. They're not really antigen presenting cells. Yeah. Sure. Yeah, so I worked with Suzanne for many years in Pittsburgh, so we were working together. Suzanne's cells are presumably T cells. You look at sort of, since we really don't know all the markers in Suzanne's, but the approach is similar to what Sam Strober does at Stanford, and they have characterized those cells as T cells. She calls them facilitator cells here, so I'm really not sure what their full phenotype is. But these are not the same. These are the cells, either the MDSCs or the hepatic stellate cells or Tregs. Perhaps, maybe, I don't know enough about her cells in terms of what their surface markers are. But we suppose that the hepatic stellate cell has a totally different mechanism of inducing tolerance than Suzanne's. But good question. You have to ask her.
So, Dr. Fung, we have a tradition here in Louisville, and some of you probably don't know this, but in the 1980s, there was this 17-year-old named Bud Hillard who was working in his dad's workshop and had gone to a ball game with what was the Louisville Eclipse, which was our old ball team back then. And there was a very famous ball player named Pete Brown. You can see a statue of him on East Main Street today in front of our ball field. And Pete had broken his back. And young Bud Hillard said, I think I can make a better bat. And that ended up being the Louisville Slugger. And that was the bat that Babe Ruth used and Ty Cobb used, Lou Gehrig, just about everybody who was somebody back then. We'd like to present this to you. I'm going to have Dr. Miller and Ms. Yam come up so that we get a picture of you with the bat.
Oh, great. Thank you.
You know how to use this thing, right?
Yeah, I sure
Don't
do.
hit either one with it.